Well, welcome all of you to AFS 2024. This is going to be an incredible meeting. It's going to be fantastic. And really, I'd like to welcome you to Colorado, which is my backyard. And one of my passions is photography. I'm not always a great photographer, but I love it. And probably that's part of what I'll start doing when I'm enjoying retirement. But I'd like to, along the way, we'll share some pictures with you. So anyway, thanks for being here. And I'll introduce Felice, whom you all know, Madam President.
Hi, everyone. Felice Schnall-Sussman. I am so excited to be here. I know that this is going to be an absolutely fantastic experience for everyone in this room and for those that haven't yet made it to the room. We are so thankful for so many things. First of all, thanks to everyone for attending. Thank you also to our faculty who has spent so much time creating engaging and thought-provoking presentations and clinical scenarios, which I know you will enjoy so much. Thank you so much to our conference team for the countless hours that they have put into organizing such a fantastic meeting, especially Kate, the Bridger Group, our AV team, and the Gaylord. And also thanks to our sponsors, without whom this meeting would not be possible. Now, before I hand this over to Michael, just wanted to bring your awareness to one thing. As president of this society, I took my responsibilities extraordinarily seriously. So much so that some of you might recognize that in addition to these puffy sleeves, there's something very special about this dress. Does anybody know what it is? That is right. These are AFS colors, and if you think that is easy to do, you are wrong. So, we are going to bring you a great meeting, totally dedicated to it. Welcome.
I want to add my welcome. I'm Mike Smith, program co-chair for this year, along with Reg Bell. And thank you to Felice as our president for your leadership, and to Reg as chair of the board as well for your leadership. We have come such a long way since the initial discussions about forming this society way back in 2018. And we wanted to give you a little bit of a timeline and a flight path for how we've come to this very day, right? We started out with a series of conversations by phone, about 6 or 7 of us, thinking about, well, what could we do to bring GIs and surgeons and everybody involved together for multidisciplinary management of foregut patients and foregut disease. And we met in Chicago, and we had a series of conversations, and things started to move forward, and we all literally put our own skin and teeth and bank accounts into the game and said, let's have a meeting in Vegas, baby, in 2019, which we did, and over 400 of you came to that. And we said, this is going great, can't wait till next year, and then COVID. But you know what? We did it virtually, and you all came out in droves for that. We had not a whole lot else going on at the time, but it certainly worked back in the spring of 2020. And we got through it, and we came back together again in Nashville at the Opryland, and we had a great time in a hybrid meeting. Some of you couldn't come in person and came in a hybrid virtual format, and the rest of you were there in person. And we said, let's keep building on that, and we got together in Orlando and Kissimmee the following year in 2022. And then last year, we put on our cowboy boots and got to Dallas, and then this year, right here in the Rockies in Denver. Next year in Dallas, and the year after that in DC, to continue to build on this. We have come such a long way. Membership now like 700-800 people from across all these disciplines, and we've got APPs, and we've got physicians, and we've got trainees, and all kinds of folks involved in the management of foregut disease. It is a really special thing, and we are just thrilled that you are all part of it and contributing to the meeting. And you know, it's important to recognize that we all come together, and that we are, as we say in our hashtag, better together. And the way we can be better together is to get on the internet. So here you go, just as a reminder, this is what you're going to use to get on the internet here, all right? And you got to make sure that you download the Whova app once you do that, because that's going to be our means of communicating with each other. You'll be able to submit some questions that way. You'll be able to network with each other that way. You'll have the full schedule right there, and you'll see advertisements that are coming up. Now, it's important. We've got a hashtag, right? Better Together, as I said before. Use that on social media. Let's build some momentum for AFS 2024, our other hashtag. All right? Remind you that during our breaks, it's important to come next door, visit our exhibit hall. You'll see some snacks there. Breakfast will be there in the morning, but also an important chance to engage with our sponsors. Again, without them, this whole meeting would not be possible. So, you know, it's important to recognize that this year we've had a theme that we've been building on really since last year's meeting, and that theme is what comes next? You know, we realize that there are a lot of meetings out there where you hear the state of the art, you hear what the guidelines are, they tell you this is what you're supposed to do something. But nobody talks about what's the next thing. And we decided that the way that we could be a different society, the unsociety, right, was that we could bring people together who don't always gather and whose traditional societies don't bring them together, and we could talk about things well beyond where other meetings go. And so you'll hear the theme of what comes next throughout this meeting. We want to go to the next step, and we want you to be involved in the discussion. And so the way that we've built this meeting is a little bit different than in past years, and it's based on your feedback from the surveys and from what you've come up and told all of us. We really want to have an interactive, clinically focused meeting. We've got case-based discussions this year throughout our different sessions. We have the opportunity for engagement with some Whova-based polling, that's why you're going to need that Whova app up and running. And we've extended the time for questions and discussion in each of the different sessions beyond what we've had in previous years. So we look forward to all of you playing as just as important part as the presenters and the moderators. All right, well, what's coming next today? Well, we've got two amazing sessions. We've got one about the care of the post-anti-reflux surgery patient, followed by a question about what do we do throughout the management of the Barrett's life cycle. Those are our two sessions for today. And then most important, after those sessions are done, we're going to see all of you on the lawn right behind the ballroom, 6 o'clock tonight for the welcome reception and party. There'll be some great games and an opportunity to get to know each other. Come up and talk to all of us. Please come introduce yourselves. If this is your first meeting, anybody here, it's your first AFS meeting? All right. Woo! Please come say hello, introduce us, tell us why you're here and what you want to see. We hope you'll all be members of the society as well and continue to get engaged. We've got great committees. We have great things going on in the society. The future is brighter and brighter, and you're all an incredibly essential part of that. So we look forward to seeing you throughout the meeting and again at 6 o'clock tonight. All right, and I think with that, we're going to move to our first session. So I'm going to bring up our moderators, Dr. John Lippum, Dr. Peter Karillis, to talk about management of the post-anti-reflux surgery patient. Gentlemen, take it away.
Here's a clicker.
And the clicker, sir. We can put that right back on here.
Get my mic live. Well, welcome again to AFS 2024. We didn't really get formal introductions, so allow me to introduce myself. My name is Peter Karillis, world-renowned gastroenterologist. I don't think I really need an introduction. My co-moderator, John Lippum, was really the only person that was available to do this. So with that being said, this is going to be a little bit different. This is going to be sort of case-based problem children that we see. Nobody likes to talk about their problem children. I don't have any problem children, but I know many of you have had problem children over the years. Most of these cases that we're going to be going over today were actually borrowed from Trip Buckley's collection. So just so you know exactly where they're coming from. So to lead us off, we're going to go over one of his most recent cases, 45-year-old male. Had anti-reflux surgery 7 years ago. Everything went great. The patient was a pretty good candidate from a symptom standpoint. Predominantly regurgitative symptoms, which to me seems to be the wheelhouse for anti-reflux surgery. Yes, they also had some heartburn and they wanted to be off their meds, but predominantly regurgitative symptoms. They had high-resolution manometry, everything looked fine there, normal peristalsis, they had about a 3-centimeter hiatal hernia. So again, as a surgeon, this to me screams like a good candidate for this. This is our initial endoscopy. You can see it there up on the screen. If you're not familiar with the new AFS grading system of the barrier, I strongly suggest that you familiarize yourself with it. It is very helpful. This would be classified as an AFS grade 4. All right, it's sort of wide open. There's a hernia there. You can kind of see the tonsils if you look closely enough. And so again, this is in the wheelhouse of a good candidate for anti-reflux surgery. They had pH testing. You can see the numbers up there. You can see the tracing. The patient obviously has quite a bit of reflux. So all in all, a good choice for a patient to undergo anti-reflux surgery. Now, as some of you may have experienced in your careers, again, not me, but initial response was excellent. But over time, it faded. Reflux started to come back. Patient got a little bit of heartburn, some regurgitative symptoms. Next thing you know, it's a slippery slope and they're back on their omeprazole. So they were seen by a GI and they underwent a barium swallow and an endoscopy and repeat pH testing. Now, what we're going to try to do with this session is sort of educate everybody on what is normal after anti-reflux surgery and what is abnormal after anti-reflux surgery. This is going to help identify what went wrong, what the problem is here. And so, with that being said, I'm going to bring up Brant Oschlager from the University of Washington, who's going to go over what is normal. What should anti-reflux surgery look like after we're done, both endoscopically as well as radiographically. You can go up there, I just wander. Whatever floats your boat, Brant.
I need to get somewhere I can see my slides a little bit. Thank you for that introduction. I have to give credit for the anti-reflux or the anti-reflux valve or barrier committee or a collaborative who spent years on defining the anti-reflux barrier, and the newest foray is into defining what a surgical reflux barrier looks like. And I am just going to try to summarize or regurgitate what is hopefully coming out in a white paper that is being reviewed by Foregut currently. And build upon all that work. So there are, this collaborative has come up with 3 components for the anti-reflux surgery barrier, and that is adequate intra-abdominal esophagus, a tight crural diaphragmatic repair, and modification of the GE junction anatomy to simulate the function of the native valve, i.e., for the most part, a fundoplication, but as we all know, there are some other techniques to do so. This builds upon the AFS components of the anti-reflux barrier, the native barrier. I won't go into this. I'm sure you're all familiar with this paper and the components. So the importance of the endoscopic analysis, and I'm going to spend most of my time endoscopically rather than radiographically, and I'll tell you why in a second, is the importance is that the anatomic modification of the EGJ seems to correlate with control of reflux. That makes sense. And likewise, the deterioration of that modification, as seen endoscopically, also correlates with failures, either recurrent hiatal hernia, disruption, malposition, whatever. It correlates with recurrent reflux and or side effects such as dysphagia. And despite this, and I'll put the onus on surgeons, is we have not routinely analyzed the endoscopic view of the GE junction valve, described it, and tried to come up with a language that is consistent and that we talk about when evaluating these procedures. And that in and of itself is the essence of the talk. So first, how do we inspect the valve? Briefly, we need to take more time. We need to insufflate the stomach, get rid of the rugal folds, spend 30 to 45 seconds to watch and make sure we can see the whole valve. This is building upon what we would do with a native valve without anti-reflux surgery, by the way. But then you should rotate and retroflex and really pull up into the especially the greater curve side to see if you can potentiate axial hiatal hernia, hiatal herniation, because not doing these maneuvers can underestimate what you have there. And then go side by side, really pulling the tip of the endoscope into the retroflex grooves on the anterior and posterior side and grade them. Now, the white paper that's coming out has gone so far as to say, well, what are the components of grading them? And I'll show them here briefly, and then I'm going to give you the algorithm in just one second. There is a whole array of nice pictures that are going to come out, and I'm going to go through a few of them for each some of the representative anti-reflux operations. But keep this sort of picture in your mind of the anterior being anterior, posterior being posterior, the lesser curve being to the screen left, and the greater curvature or angle of His to the right. And you can see some schematics that are going to come up along the way. So here's the algorithm that's being proposed for everyone doing endoscopy after anti-reflux surgery. Is first look and say, is the hiatus visible? Do we have a hiatal hernia? And then sort of describe that. Then go to, if you don't have a hiatal hernia, you should be able to see the anterior and posterior grooves and be able to measure and describe those. What is the apposition of the fundoplication to the scope? What is the length, especially on the angle of His or greater curve side? What is the length of the valve? And what is the characteristic? Can you see the squamoclaminoid junction at the lip of the valve, somewhat assuring yourself that you have completely intrathoracic esophagus? So I'm going to go real quickly. This is, again, all hopefully coming out in publication very soon. But just to get us started, what should these things look like? And this is an AP Nissen fundoplication, sort of the tightest of the valves, where you'll see a deep anterior and posterior groove. Should see tight apposition of the valve against the scope, and it's somewhat symmetric as you look on the schematics to your right. A toupee really should be, in my opinion, slightly coming short of a Nissen. However you do it, the geometry should be the same, but in stopping short, your posterior groove is going to be a little deeper than your anterior groove, and it's going to be a little less tight. And I'm already cut off. I guess I ran out of time.
No. I think we have the end show button up on the screen, on the presenter screen.
I promise I'm within a minute.
Did
of
somebody?
being done.
Come on, he's almost
done. So
done.
this is the toupee. The next thing you'll see is an anterior fundoplication where you see the anterior groove being more pronounced than the posterior groove. Something's happening.
Hold on. Now you're back. No, you're not.
And then I'll show you. I think I have a picture of the TIF. And then finally, so there's the anterior. That's what that looks like. And let's skip on over to radiography and just say, endoscopy is probably more important if we do this right. The advantage of radiology is that it doesn't take sedation. The other thing is it's more transferable, because so far the radiologists have figured out how to transfer their images, their representative images, universally to other institutions, whereas endoscopists have not. I see 90% black and white images smudged and very few good images, and even if I do, very few have taken all these components so I can really see what is happening. So in conclusion, we need to have a common language, and if you get nothing else from my talk at least, it's an emphasis that we as surgeons and gastroenterologists need to start having a common language to describe the anti-reflux valve so that we can compare and contrast different versions of these anti-reflux procedures to really start to understand if there are any differences, and if so, what are they and what are the advantages. Thank you.
All right, well, now at least we understand what it should look like. Now, obviously, to make sense of all this, we got to know what it shouldn't look like. And so this is where we weighed heavily on Reg Bell and Trip Buckley to go over this. Stephanie Worrell from the University of Arizona is going to present what is not right about these patients.
All right, so that was a nice setup for us, what I'm going to show you next here. So what we all know, there's about 20,000 anti-reflux surgeries performed annually. Most commonly, these are performed for symptoms, but a small percent are not performed for symptoms. But only a small percentage, about 10 to 20% of patients are going to have persistent, recurrent, or even new symptoms after their surgery. And only a smaller percentage, about 3 to 6%, will need a redo operation. So that really only translates to about 60 to 240 people getting a reoperation every year. So even though we think we do a lot of reoperations, not a single surgeon's doing a high volume of reoperation. And then the most common reasons, the causes for failure that lead to symptoms are the following: recurrent hiatal hernia, that happens most commonly; slipped wrap, which can lead to a completely disrupted wrap. And in my practice, or in probably in many people's practice, what I commonly see is a combination of hiatal hernia and slipped wrap. This here is a case I did recently. It was a redo, not first my own, but they had a hiatal hernia, a recurrent hiatal hernia, and you can see that there is stomach above that wrap. I doubt anyone put that wrap across the fundus of the stomach intentionally. It's slipped down, and now they're having, you can imagine, significant dysphagia. They have an artificial gastric outlet obstruction from that slipped wrap down onto the fundus of the stomach. And so not all recurrences or abnormalities are going to look the same. And they're not going to all respond the same. So that's why understanding and having this common language for endoscopy, looking at imaging, is important. Sometimes you have to figure it out when you're in the operating room if you're going back. And there is not really a common language yet. So I think this paper that's coming out will be terrific. There are a couple classification systems that have come out. Marco Patti had one. It doesn't really describe if it's like from endoscopy or esophagram, but it really is just emphasizing where the GE junction and the wrap are in relative to where the diaphragm is. And so that picture you saw would be considered a type 2, where part of the stomach is above the wrap and it's all herniated up above the diaphragm. And then Sumit Mittal came out with an endoscopic classification system, which it sort of mirrors, and I think that it's kind of a prequel to what is coming out with it from AFS, where the E component is that distance from the GE junction up to the level of the diaphragm. And then the S component is the amount of gastric tissue above the fundoplication, and then a description of the actual fundoplication itself. And so not all anti-reflux abnormalities after anti-reflux surgery need another operation. And we try to avoid it if possible, if you can manage symptoms. And I think we'll talk a little bit more about that in some of the future talks that are coming up, because the success rate of a redo anti-reflux surgery is really less than 70%. And not all causes really respond the same. So your real opportunity as a surgeon is really at that first redo operation. You want to do something different than the first surgeon did, and you want to improve upon it. Every subsequent redo operation is going to have worse overall success. And after 3, it's really prohibitive, and I'm thinking about something else. So as a thoracic surgeon, I'm going to do a transthoracic approach, but you could consider esophagectomy and Roux-en-Y. And when you think about that, you have to think your patient has to be very symptomatic, because you're going to try to make them better than they are now. And so I'm going to show a couple pictures here. So this was a lady, 67-year-old. She had 2 failed fundoplications. Her initial Nissen was actually in 2010, and she did really well for about 10 years. Then she had a redo in 2019 and almost immediate symptom recurrence. She came in with dysphagia and severe heartburn. So endoscopy, you can see she has evidence of LA grade C esophagitis. And you can see here what this wrap looks like. It was supposed to be a Nissen, And as Dr. Oschlager alluded to, a normal Nissen is supposed to have this stacked coin appearance all circumferentially around the scope, snug up on that scope. But you can see here, this is probably what we would call loose Nissen, because it is going around the scope. It's not quite as high of a height you'd expect to see, and it's definitely not snug around the scope. And then next to it, the importance of staying in retroflex for about 45 seconds to really distend the stomach is because these hernias are not really obvious if you have the stomach partially collapsed. So you have to completely distend the stomach, and then you can see that there is a hiatal hernia component adjacent to that. And then I think manometry isn't always quite as helpful for these cases, just because if the wrap is below the diaphragm, it doesn't always give you a clue about the hiatal hernia. I think in that scenario, the esophagram is actually better. And I think esophagram, it's not going to tell us a lot of information about the wrap, but it is going to give us a good roadmap of the anatomy. And so and a good idea of what the motility is like. And so take a look at this one here. Sorry, the video is a little slow motion, but what we'll see is that, she had relatively preserved motility. The wrap is below the diaphragm, but you can see sneaking up behind it is a portion of the fundus. And so, you can get an idea that the wrap is a little bit loose here because the contrast is going through it so rapidly. And so just another example, 56-year-old, she had a hiatal hernia with a robotic repair for a toupee, had obesity, prediabetes. You could argue that maybe with a BMI of 36, maybe toupee wasn't the best first option for her, and she had some definite motility issues to start with. And so we do an esophagram, and she obviously has a large recurrent hiatal hernia. And so the video in this one is, it just shows it much nicer. You can see that the wrap is actually, are you able to play the video? The wrap is actually above the diaphragm, and although it's intact, it's all up above the diaphragm and widely open. And so you can see the wrap is what you can imagine was a toupee, full of contrast, and then all of that up above the diaphragm. And you can see that it's probably loose at this point because you see the contrast just freely flowing through there. And so a couple other examples of abnormal endoscopic findings. I agree with Dr. Oschlager. I think that the endoscopy images give you a lot more information about what happened and what's going wrong now. So this is what I would consider a twisted wrap with a paraesophageal hernia. You can see those folds are really twisted around. In any of our conventional wraps, they really shouldn't be kind of twisting around the scope itself. And then with more distension, you can see a component of a paraesophageal hernia. Again, this is a toupee, and actually this toupee looks relatively intact. So the toupee should have that kind of omega shape, and it is snuck up against the scope, but as you distend, you can see that there's a paraesophageal hernia component that's popping up underneath that wrap. So always spending a little bit more time in retroflex will give you a lot of information about the quality of that anti-reflux surgery. And then this lady came with significant acid reflux. And on first retroflex view, she had a Nissen, and it looked relatively normal. It's a pretty thick valve. It looks like it was going all the way around. But as you come down, you can see that this is clearly not at the GE junction. That has slipped down onto the stomach, probably what is causing her a lot of that acid reflux that she's feeling in her esophagus. And then finally, other things. So, most of us have shifted to not putting permanent mesh around the esophagus or the hiatus, but people still use felt pledgets. And so this lady came in with a significant dysphagia, and her Nissen was actually intact, but her felt pledgets had actually eroded through the stomach themselves. So lots of stuff that you can see, all of it's on retroflex. Spend a little bit more time there. And I think with a thorough preoperative workup, post-anti-reflux surgery abnormalities are actually pretty rare. So, and particularly people who are going to need surgery, that's even more rare. But if you understand what a normal and an abnormal one looks like on both endoscopy and manometry or esophagram, it's going to really help you understand what you should do about those problems. And remember, not all these abnormalities are going to require surgery. Very few of them actually will. And if you're thinking about doing a third or fourth, I would say, maybe consider something else. Thank you.
All right, so now we're going to circle back. We're going to go back to that patient of TRIPS and see what we found. They did an endoscopy, they did pH testing like we talked about, they did a barium swallow. And this is the barium swallow that you get back. So this should, if everything's working correctly, be on your Whova app. And so if you can pull out your phones, go to Whova. You were, okay. Reverse order, okay. So you got to see the image for a brief second there. Now, I didn't push that to go forward, but okay. And so then you do an endoscopy, and you see this. Does that look normal to you guys? Anybody want to raise their hand, get up to the mic, say it looks normal? Does it look abnormal? What happened here? What do you think went wrong? So again, if you could answer that into the Whova app. Wait, somebody's going to volunteer?
I'm volunteering Mike Smith to
Oh.
pass the microphone out.
Oh, okay. You're volunteering, Mike. Got it. All right, so we'll give you a couple of seconds to answer that. So it looks like the vast majority are saying it looks like a disrupted and herniated fundoplication. Does everybody agree on the panel with that? Brent? Disrupted and herniated fundoplication.
So my only problem is, I've been doing this for 25 years. I've never seen a Nissen be disrupted.
Bingo. Okay, I'm going to marry him. That is the exact answer we wanted.
He didn't even tell me.
No, we're meant to be. Keep going on that, and then I'll chime in.
Well, I mean, so they can loosen, they can become attenuated, they can be stressed by hiatal hernia and various other things, but they don't pull apart. I mean, unless they were never together in the first place. I have seen some that I thought maybe that was the case, but
What about with paraesophageal hernia?
They can be stretched, but if the sutures, if they're bringing the fundus together, the sutures are always there, and there's some adhesion, even if it's stretched, continuing to pull those things together. So maybe it's semantics. The reason I emphasize it here and with trainees and such is that I have seen many op reports of when I go down for a third time, where people describe, oh, there was a hiatal hernia and the fundoplication was completely apart and disrupted, so I just redid it. And then when I go in the third time, I find, okay, yeah, you did that, and then I take that apart, and then I go back in, and then under that, there's another fundoplication. There's a fundoplication of a fundoplication, and that never works.
Well, I would take it even a step further. I agree, the wraps never become disrupted. They don't come apart, reattach themselves to the spleen, number one. Number two, endoscopically, they always look disrupted. And I think that's where it comes from, because in the presence of a recurrent hiatal hernia, the wraps don't work. It's wide open. They look like they either don't exist or they're twisted or something. I would take it even one step further and say if you go in there as a surgeon and fix that recurrent hernia and do an endoscopy after the hernia is fixed, over 80% of the time that fundoplication will be fine. It will be intact, and I would argue I don't know as if it necessarily needs to be redone. So again, the wraps don't become disrupted, so even though everybody answered B, to me I think it's more A. Peter? Stephanie?
Well, I think you might have changed my mind, but I would have initially said that was a disrupted herniated fundoplication. But I would emphasize that endoscopists don't focus enough on the hiatal repair. And that is always a mechanism of breakdown.
85% of the time anti-reflux surgery goes wrong. It goes wrong because of recurrence of the hiatal hernia.
So the problem with the explanation is that looks disrupted on the picture.
Leave it to Dr. Katz to disrupt the bleeding already.
Yeah, Mike's not doing his job.
Sorry, Phil Katz from Cornell. When you look at that picture, okay, that looks disrupted. Now maybe it's not disrupted to a surgeon who goes in there and looked at it. So the nomenclature is a problem. The way Brandt explained it is we should be able to see that endoscopically, okay? And Peter thought it was disrupted. So did I, based on the picture. So
It always looks like that. It will always look like.
Please understand, you're trying to get gastroenterologists to be able to look carefully in retroflexion and describe what's going on, and surgeons to do the same. I make the case that it's clear the hiatal hernia repair is disrupted, but to most of us, that's a disrupted fundoplication. If it doesn't happen that way, then change the wording.
Well, that's why we're here, and that's what I think we need to do, is we need to change the wording. Because like I said, if I went in there and fixed that recurrent hiatal hernia and did another endoscopy right then and there, that would look like a beautiful wrap. It's part of what's going on with the mechanics of whether being it intra-abdominal, intrathoracic changes how that wrap's going to look. Stephanie, or Brent.
Go ahead.
Yeah, no, I was going to agree. I think I don't know that when I reduce them, I don't think it ever looks like a good Nissen again. I could say maybe it
Well,
looks,
if I did it, right?
I've never had it where I reduce it and I'm happy with how that wrap looked before. Maybe it looks more like a toupee, you know, like it's loosened. But I think when it gets pulled up into the hiatus and like stretched apart like that, I think the anatomy has just distorted. And so I always do something to that fundoplication.
Real quick, Brent, we published on this 3 years ago and found that 85% of the time we didn't have to redo the wraps. And that once we fixed the hiatal hernia, that was it. And those patients, pH negative, symptomatically better, the wraps were fine. 15% of the time we did.
Yeah.
Brent? Call it distorted. Distorted, I like that.
So I think that if you are high volume people in this group, knowing what you do with the fundoplication and you're redoing your own, and I have done what you're saying sometimes, because I have had 1 or 2 failures, then that's okay. I would submit 2 things though. One is, if you're redoing someone else's, I don't think you can tell all the potential small problems or even big problems. Maybe I'll be learning with just putting a scope in and saying, oh, that looks fine. I feel like I've routinely had to take everything down to find all the problems and the ways that I can improve the fundoplication. That's number one. Number two, to what Stephanie was saying is the mechanical effect of a hiatal hernia, or just the stress of living with one, can stretch things enough that even a good repair does not always continue to be a good repair. I don't know whether it's 15% of the time or more, but I would be acutely aware and not say, well, I did it, it must be still good. As long as I do the hiatal hernia repair, I don't need to redo the fundoplication in any sort of way.
No, I'm not saying that. I'm just saying you need to check. You need to do your own intraoperative endoscopy and take a look at the status of the repair, and you'll be surprised. A lot of the time, maybe not 85, but it will look normal. So, questions? Mike, we have a question in the back.
Missy D'Souza from Portland, Oregon. I really appreciate this talk, and I appreciate a lot of what we're talking about with the nomenclature, and I think to what Phil was saying in terms of how we communicate with each other, GIs and foregut surgeons. All of the foregut surgeons in this room are here because we are invested in this high quality, high volume surgery. And so to the whole point of whether this looks disrupted or not, I think the importance is, number one, if you're working with a surgeon who's coming to AFS, then they probably have some idea of what they're doing when they're making a fundo, but not all surgeons out there will construct a wrap properly. You know, Brant had talked about the slipped versus the misconstructed fundoplication in a session earlier. And I think the important thing is, if there's concern about the nomenclature, just make sure that we are talking to each other. Get that GI to refer to a high volume surgeon. And so how we can figure out getting that knowledge out there so our GIs in the community know who those people are, that's really kind of one of the other things I want to see with this.
Felice.
So in all honesty, I chose the...
Speaking to my chest.
It's a very exciting orientation, but I'll use the microphone. You know, in all honesty, I answered B, and then I sat here really embarrassed that I answered B, and I thought, my God, I don't know
Okay,
what the heck
I'll
I'm
squeeze
looking
through
at.
'em.
And I realized, you know, there are two things that actually happens when a patient returns to me and they've had a fundoplication, a hiatal hernia repair. One, when I look at, in retroflex at the G-junction, in some respect, you feel a little intimidated calling the surgeon and saying, I don't think your surgery looks good any longer. I mean, there's this weird kind of thing to call a surgeon and say, I'm pretty sure that surgery that we, you know, bolstered up the patient to go for and whatnot looks like poop right now. That's a gastroenterologist.
They skipped
that's why I
question
use that
2.
term.
I'm going to put it back
But,
up.
Okay.
but I think,
Well, I can do
you
it.
know, the other piece is, I think we really need a picture endoscopically close to the surgery of what it looked like in the
That's
retroflex
3.
view, because that would be really helpful to
skipped.
us. So if there was, in the electronic medical record, a picture of the valve looking pristine, and then we brought the patient back afterwards, let's say a year or two, whatnot, and they weren't feeling good, we would then have something to compare. And I bet we would really learn what it should look like and when something looks distorted or disrupted.
All right, well, I think we're kind of running a little bit on time, right?
Sure.
So I think we're going to kind of scream through these parts, but I mean, this is the next question, and hopefully
Actually,
you've already...
put up question 2, please. There you go.
But I think we kind of went over this. This is the X-ray version of the endoscopic image we showed you. And again, we can go over the semantics of this, but what are you looking at? And hopefully it should be pretty clear. You can kind of see the pinch of the diaphragm there. You can see something above the diaphragm. I love Ellen's response, which was, it's a distorted herniated wrap. So, and now if you need little drawings, you can see it a little bit better. And then question 3 is, what are you going to do? And here I don't think there's really a right or a wrong answer. I 100% agree with Stephanie. If they haven't had a redo, redo's on the table. If they've already been down the redo path a couple of times, it becomes a little bit like the definition of insanity. So, with that being...
So if people are having problems following this, because we're not seeing a lot of responses here, so you go to agenda, you choose the session, and then it will show polls. So that's how you get into it. So
Agenda, session, polls.
polls.
Okay,
Okay.
got it. Thank you, Reg. All right, so if we get this back up, and I will hand over the,
We're supposed to just, do you want to discuss that or no?
well, I thought we were kind of running on time, so.
We got till 3 o'clock and then a little discussion. At least
right,
look at what they put up.
Peter says we can keep going for a little bit.
Put up the audience response to...
Yeah, if we go back to the audience response.
There you go.
All right, so most in the audience would redo hiatal hernia repair, plus minus redo the fundoplication. I'm assuming those answers are mostly the surgeon's answers. Any of the gastroenterologists answer repeat lap Nissen? Raise your hand, just one. Just one. Yes, right down here. Okay, 2. Oh, wow. My lucky day. All right, so the others said continue PPIs, increase to twice daily PPIs, or switch to Voquezna. Stu, what should we do? You're the PPI PCAB expert.
Well, there's not much difference, frankly, between the switching to twice a day omeprazole or Voquezna. So I think either one of those is okay. I'm not sure what this patient's primary symptom is. Is it heartburn?
Heartburn.
Heartburn.
Yeah.
And it's responsive to therapy.
Then I would increase the dose of something and try that before going to a redo operation. I don't think redo operation is wrong, okay? I don't. But I think I would try medical therapy first.
What would push you to push or put them on Voquezna?
Well, if you're having trouble with them, frankly, it's, esomeprazole 40 twice a day is about the same as Voquezna once a day, okay? So, you know, either one of those is acceptable. I think that Voquezna is a little easier to take once a day than having to worry about taking it twice a day. But I think either one of those would be acceptable. You know, the choice between the two has not been studied, but in terms of acid suppression, it's going to be about equal. If it's regurgitation this patient's complaining of, then I'd go quickly to the redo repair. But if it's just heartburn, I'd try medicine.
Bill?
I think unfortunately we don't know how much acid exposure this person had before they were operated on originally. This is something that would be labeled an abnormal wireless pH study, mild at best, however, would barely meet Lyon criteria for actionable GERD, would meet Yadlapati-Pandolfino's criteria for abnormal because it's greater than 4%. This person will end up on a TCA in our practice because their symptoms won't go away with acid suppression, although we would probably do what was suggested, and we would definitely use vonoprazan. It would be absolutely not debated.
Yeah, I think the point made by Stephanie was not every problem needs to be fixed, because sometimes the fix is too hard. And I would base the decision here myself on whether or not you are getting adequate symptom control with PPIs. As Reg Bell said this morning, you know, taking somebody from an intolerable situation to a situation where they're responding fine to a PPI is enough. You don't have to necessarily operate on them. Well, so let's move on to case number 2. Postoperative dysphagia. We have a 45-year-old female seen in consultation 3 months post 12-bead LINX placement for solid food dysphagia. Surgery was initially done for PPI-responsive GERD, primarily heartburn, but she did not want to take PPIs because of osteoporosis. Pre-op HRM showed normal peristalsis and 2 centimeters of LES-CD separation. Dysphagia had become progressively worse, leading her to adopt a liquid diet. Consults with her GI, and she ordered EGD and FLIP and a barium swallow with a tablet challenge. Endoscopically, the EGJ was snug but intact. FLIP panometry then was done, and this is what it looked like. What are you looking at? And you can use your HUVA to enter your response. Normal contractility, type 3 achalasia, repetitive retrograde contractions with reduced EGJ opening, or spastic reactive contractile response and reduced EGJ opening. And here are the responses. About 40% are saying normal contractility and reduced EGJ opening, and the rest say repetitive retrograde contractions and RIO. Can I advance the slide? There we go. Well, I think you have your work cut out for you, Dusty. You're up.
All right, well, thanks, Peter. And yeah, it's great to be here, back at AFS in Among the Mountains. And so I get the task of talking about abnormal post-anti-reflux surgery physiology. And first just kind of framing this with a few cases here, but thinking about dysphagia after fundoplication, as we've now shifted from kind of symptoms and more focused on dysphagia, but it comes in a variety of different sizes and shapes. It's a very heterogeneous disease, or at least clinical entity that can present in different ways and specifically from different forms. And I think when we come down to identifying treatment and how we address this, identifying the underlying why as to what's causing dysphagia is important. So we'll come back to these cases a little bit, but first off, thinking about an approach here with, a patient comes in to see us for symptoms. We gather that from the history. How long is it from the fundoplication? What type of anti-reflux surgery did they have? Why did they have the anti-reflux surgery? Was there dysphagia before the anti-reflux surgery? But ultimately trying to narrow it down to see what is the consequence, perhaps causing that symptom. Is it impaired clearance? Is it reflux? And then putting that together using the tools we have to identify both anatomy, typically done with endoscopy and esophagram, as we've so nicely seen already earlier in the session, and then bringing in the physiology. And when I hear physiology, I think more about manometry, starting to think about flip, and in somewhat thinking about esophagram as well. But also in interpreting this abnormal physiology, really recognizing that anatomy and mechanical obstruction of the esophagus can have a major impact on what the esophagus is doing and on the physiology of our testing and of the physiology of the esophagus. And then when it comes back to identifying why people are having symptoms, you recognize that there are also other factors that can have an impact, and things like sensitivity and perception and anxiety, among others, can also drive symptoms here. So before we get into what's abnormal post-reflux, post-surgery physiology, think about what's normal post-anti-reflux surgery physiology. And the Chicago classification, for all of its goods and bads, is intended to identify primary motor disorders. And so the thresholds, the values, the classification schemes there are intended to apply to patients without prior surgical foregut intervention. There are several studies that have looked at this among patients. Looks like I got cut off a little bit. But the values from manometry, IRP values, vary depending on a few different factors. They vary depending on what assembly you're using. That made by Sierra, now distributed by Medtronic, will have different values than if you're using a Diversitech or Laborie catheter. Also may vary depending on if you're in the supine or upright position. Long and short of this, the wrap, the type of manometry assembly, the type of position, will have the higher after anti-reflux surgery among patients who are normal, asymptomatic, feeling well, often with good reflux profiles, than those defined by the Chicago classification. So the Chicago classification is great for helping us use a common language. We talk about looking at endoscopy and using common terms. I like disrupted. I'm going to start using that. Or at least, what do we say? Distorted, distorted. I'll keep saying it. It'll stick. But the Chicago classification falls outside of that for manometry. What about flip? Really normal values on what flip should look like when someone returns long after a fundoplication are not as well defined. We did a study a couple years ago now looking at among a large cohort of patients that had symptoms after fundoplication and tried to break it down and look at different mechanisms, or at least different anatomic configurations of the fundoplication, and really saw that the flip findings, extensibility, diameter, had a pretty wide range across all these different anatomic formations of a fundoplication. So variability, and I think something that gets interpreted in the context of the anatomy and potential physiology. All right, what about peristalsis? This is where the esophagus is actually a beautifully reactive and adaptive organ. The esophagus will squeeze harder when you're lying down than if you're standing up. If you take a sip of water standing up, it may not even have peristalsis triggered at all. It'll just pass with gravity alone. But a nice study from Tom DeMeester from a number of years ago now looked at this, looking at patients using wave amplitude on manometry from before to after fundoplication, and showed a few things here. One, in that most patients will actually have an increase in peristaltic vigor with an increase in wave amplitude. And is that from correction of the hiatal hernia? Is that from bolstering the anti-reflux barrier, causing a little additional resistance? But most patients will actually increase their peristaltic vigor. There, however, also appeared to be a breaking point, a bit of a threshold where some patients did not have this. And this may have some other impact for how they have symptoms after surgery. But another study that I really like, and this is not an anti-reflux surgery study. This was actually a study out of Australia where they took patients who had a lap band. And it had nothing to do with whether or not they were having symptoms, but they brought these patients in and put a manometer down across their esophagus, and then they adjusted the lap band. Overfilled it, emptied it, and I think a couple really interesting things that came out of this is that when the lap band was overinflated, it was 20% over the optimal volume, there was a lot of these reactive and abnormal looking peristaltic parameters that were observed. Repetitive contractions, hypertensive contractions, and this just kind of as a finding indicating that the esophagus is going to react to obstruction or to even maybe just a level of increased resistance. So also in interpreting manometry after fundoplication, there's been a recent effort in the spirit of consensus and working together of a group of gastroenterologists, group of surgeons who came together to form the PADOVA classification. So a couple slides I get to present from that Reina and Renato had shared with me. But the starting point in using manometry after anti-reflux surgery starts with defining anatomy on the manometry and really looking at the distal high pressure zone. Is it a single separation, a single high pressure zone, indicating that there's potentially not anatomic disruption? Or is there a dual high pressure zone? And then breaking it down based on where the crura is, where the LES is, to try to identify potentially the mode of failure that has occurred with the fundoplication. Now, they can break this down using this with the distal intrathoracic wraps based on really where the wrap is, also defined with the manometric high pressure zone. I did notice after the fact that this third one here doesn't match the anatomic picture, but case said that when when the wrap is at the distal high pressure zone, that may indicate a slipped wrap versus an intrathoracic wrap when the wrap is at the level of the LES. But then they took it down farther, and now when there's not separation, when there's a single high pressure zone, to try to look at this in a hierarchical fashion, modeling the Chicago classification, but applied now after foregut surgery, anti-reflux procedure, to see whether or not there is low basal pressure, is there an elevated IRP, and if there is, and there's peristalsis, they came up with a new syndrome, the post-fundoplication outflow obstruction, or PFOO. I didn't just sneeze there. That was another acronym now that we have. I know we've been talking about how we needed more acronyms in esophagology, so appreciate the investigators, the work that to have this one to add to the mix as well. But a manometric pattern now that is defined by elevated IRP and increase in intrabolus pressure, not relying solely on the IRP to define this entity. But also looking at, I think another important part here is when there is elevated resistance at the EGJ and there's failed peristalsis, to look at this in kind of in the context of whether or not this is pre-existing or this is new. Now, to answer that question, you have to have known what things looked like prior to an anti-reflux surgery. And even though I think a lot of times the discussion, the conversation about the value of preoperative manometry somehow gets focused and tailored into, can I tailor a partial to a full fundoplication to if there's ineffective motility? A lot of it comes down to ruling out achalasia. And a very essential part here that gets brought out, I think, in this document, and this is overall a nice piece, in addition to having PFOO as well. All right, so coming back to a few of our patients here now. First one, this is a long time ago, having dysphagia, manometry with an absent peristalsis, and also very low pressures here in a dual high pressure zone. This fits a hiatal hernia. This was a wrap that I would actually think was disrupted. It was nearly discernible or undiscernible that there was any previous fundoplication on the endoscopy. And so this would be considered a disrupted fundoplication, a distorted fundoplication with a hiatal hernia and absent peristalsis. Another one with early dysphagia shortly after having a toupee fundoplication and a repair of a large perisophageal hernia. I'm coming in now with significant dysphagia, an esophagram that really looks beaked and almost like a pseudoachalasia pattern. The manometry didn't detect it actually had normal LES pressures on manometry, but endoflip showing more of this achalasia pattern. And then finally, a patient here that had a perisophageal hernia that actually included a portion of the wrap, and this very abnormal manometry, meeting our elevated IRP as well as intrabolus pressurization, and this abnormal repetitive type hypercontractile peristalsis here, all likely manifesting a secondary response to the obstruction from the perisophageal hernia. And so just to summarize then, think about this really from these various different mechanical, anatomic, and physiologic factors that may drive symptoms, and particularly dysphagia after an anti-reflux surgery. But ultimately, using a number of tools in the toolbox to have a comprehensive approach to help identify the underlying mechanism, and these really important interactions between anatomy, physiology, consequence, and symptoms. All right, thanks.
Thanks, Dusty.
Let's go to the empty couch, I think. Yes.
So the patient then had a barium esophagram, and you're looking at that there. What are you looking at? achalasia, delayed esophageal emptying with an impacted tablet at the EGJ, normal post-LINX study, or herniated LINX. Use your hoover.
That just sounds so wrong.
Yes, it does. And we have, I don't know, I'm going to call that 60-40 between delayed empty. Oh, that looks better now. Yes. Normal post-LINX and herniated LINX versus delayed esophageal emptying with an impacted tablet at the EGJ, which is how I would have voted. Can you advance that? I think you're up, Christy. And post-ARS dysphagia, what are your options? Christy Dunst. Ooh, I'm almost down.
Almost lost you, Peter.
Is it the big green one?
Huh?
Yep.
Yeah,
Okay.
the green one.
All right, well, thanks for the opportunity to talk about this. This can be obviously super complicated, and that's why we gave it to Dusty. There, thank you for that. I'm going to make it a little more simple in that this is really what you do about it, post-anti-reflux surgery dysphagia. You try conservative management, then you move to an endoscopic dilation, and then ultimately a revision, which several people have already mentioned today, is to be avoided if we can help it. So we'll start with the LINX, given the case. And it's important to understand the natural healing history when you implant a LINX. And the dysphagia usually does not happen until somewhere after 3 weeks, maybe 3 to 10 or something like that. And that correlates to normal wound healing that we all learned in the Guyton text in medical school. And the beginning is the inflammation proliferation phase, and once the remodeling starts is when it lays down a bunch of collagen and that device gets a little bit tight. So while it's remodeling, you can potentially have an impact of diet modification. And so if you have a patient who, at the beginning, they had their LINX, at the first few weeks, they're doing awesome, they're eating whatever they want, and then it starts to get a little tight. First of all, they should have been warned about that, so they don't freak out. But if they call your office and they're otherwise doing okay, you can tell them to back off their diet a little bit, and maybe even go to liquids. But it's important that we don't want that device to freeze. Just like when you have a knee replacement, they need to do physical therapy, move their knee around. So even if they're going back down to a liquid diet, have them take a bolus of food at least a few times a day and pop out the device. Generally, they'll get better fairly quickly. In this early period, especially if it's more toward the 3-week zone, there has been, some people advocate a little dose of steroid because that's still sort of the early inflammatory phase, and that's completely fine. But if it lasts beyond, or the severity is such that they're not being hydrated, then you're probably going to want to bring them in for a dilation pretty quickly. Now, in our early experience, there weren't a whole lot. We didn't really know what to do. How do we dilate? When do we dilate? When do we do steroids? When do we do all this stuff? And a few years ago, a bunch of us got together and just kind of polled our experience. So this is really, it's a retrospective review, but really I look at it more of a survey of experienced users and what were we doing. So multi-center retrospective review of our practice. And there were 245 dilations in 144 patients. Most of the people used an 18 millimeter balloon. Some used a bougie. No fluoroscopy was most common. A few people used fluoroscopy. That's what people were doing. And this is really demographic to show you because there's no denominator, but there really wasn't an obvious aha moment when you kind of looked at number of dilations and size of the devices and that sort of thing. But the most important thing to notice that we noticed was it was reassuring on the one hand, in that most people got better after a couple dilations. You know, you bring them in, you put the balloon in, dilate them, and most of the time they got better. But if their dysphagia was bad enough to require a dilation, it was almost a 12% chance that it would eventually be explanted. So that was, you're hoping, okay, bring them in, get a dilation, and if that works, you're really happy. Second dilation, you're happy, but if you go beyond that, it's a concern. But still, the overall success rate with dilating them to get them over the hump was 83%. So I'm going to show you this video. It's very, very quick. But to show you that I wanted everyone to see, saying just take it out is not nothing. There's a lot of adhesions. I mean, if they have to come out, then they have to come out. But the device gets really embedded into the esophagus. This also demonstrates the reason why erosions aren't as a big deal as we thought they would be at the beginning of this experience, because it really gets impacted in there. You can pull it out. This looks like you're digging in the esophagus, but you're really just opening the capsule. And then this happens a lot of times, it kind of splits in half because you don't want to go circumferentially with your dissection because you'll bag the vagus nerve. So that's sort of the link's sort of history. Now, contrast that with post-fundoplication dysphagia. Post-fundoplication dysphagia happens at first. I think all the surgeons in here for sure know that you tell them you modify their diet in some way, liquids at least a week or two, or maybe a little bit more. Tell them it's going to take a couple months, sometimes quicker, but prepare them that it may take a couple months to get advanced to a regular diet. But it should improve. It should improve. And generally, unless they really can't swallow and you really messed up your surgery, you don't have to do much. Just reassure them for the first few months. But what if it happens? What if it lasts? You know, it's more than they've been calling you for a couple weeks or a couple months now, and you've been like, just wait it out, wait it out, wait it out. Finally, you get to the 3-month mark, and you're like, they're still calling. Get your X-ray, and let's see. This should play, but it's not. Thanks. So this person had prolonged dysphagia. I'm just going to fast forward. They had their endoscopy looked okay. Their HRM was okay. They didn't have new achalasia. But you can see that is tight. That is a tight hiatus. And you can see the tie knots in there, and the esophagus is it's getting dilated against that hiatal closure. You can't really tell, is it hiatus or is it fundo? But I suspect on this it is it is the hiatus. Let's see. It does empty, so they're not dying. This is why you're able to tell them, yeah, just have liquids a little bit longer. Okay, and then this is also a video, but it just shows that the barium tablet hangs up post-op. Okay. So what are you going to do with that person? You're going to take them to endoscopy and you're going to dilate them. And if they respond, it's likely a tight crura. And that X-ray looked like that's probably the case. And you're going to be able to fix them pretty quickly. I think several people in this morning session have sort of mentioned about making sure that the crural closure is tailored to the esophagus, because we can fix that. If you overshoot that, we can dilate, you pop a little stitch, you stretch it out. So if they respond to an endoscopic dilation, it's likely a tight crura, things will probably be fine. If they didn't respond, then you need to consider that you messed up their fundo. And it's going to be an individual situation on whether or not you revise it. But fundos don't generally respond to a dilation. And I'm not saying rush them off to surgery, but if they're not sufficiently better, take a good look at that. And now this is just a picture of a recurrent paraesophageal hernia. We could show a million of them. We all recognize they all have different shapes and whatever. But this is a recurrent hernia. And I want to show you, this is that same patient's endoscopy, which on the right, it's like you blow it up. It doesn't look terrible. It looks like a kind of loose wrap. But then you blow it up more and you start to see this little tiny opening. And that's pretty significant wad of of herniated fundo in there, I would say. So what are you going to do about that? Any sort of mechanical problem, big hernia. The question is, are they a surgical candidate? Because that's, no medicine's going to help. Are they a surgical candidate? If they are, then consider revision surgery. I completely agree with everyone's comments. Keep them out of the OR if you can. So evaluate them, whether or not the pros and cons are worth it. But that is a problem that is not going to get better without surgery if they can't live with it. But if they're not a surgical candidate, dilate them anyway. Dilate them anyway. We've all seen patients who we don't know why they respond to the dilation, but it helps. It keeps them out of the OR. So, and again, I would dilate it. I would dilate them regardless. But a dilation can sometimes help anyway. So at the end, that was a very quick kind of overview look at the progression of conservative management, endoscopic dilation, and then revision when necessary, which we'll talk about more on the panel.
Thank you, Christy. So this is another HUVA opportunity. Assuming that our patient had flip panometry with spastic reactive contractile response and reduced EGJ opening and the radiograph with an impacted tablet, what would you do? Remove the links and replace it with a larger one, serial dilations, remove the links and construct a toupee partial fundoplication, or the same with a Nissen fundoplication. Enter your responses. Nobody for dilation.
Update the poll.
What's going on?
They need to refresh the poll.
Oh, there we go.
Christy's talk worked.
If only elections changed that quickly. All right. Now I think we're going to discussion. Can you advance that? Oh no, that's the next case. Okay, so it's us to discuss that case until 2:10. That's open for discussion at this point.
Oh, the last case, questions?
Yeah, thanks. So you said serial dilations, but Christy, when you were showing us the links thing, it sounded like you do one dilation. You're doing a big dilation there. I mean, as gastroenterologists, we think of strictures. We're going to progressively dilate these things, but it sounds like you want to rip this thing open at one shot. Is that correct?
Well, serial dilation is a good question. I think most of us we kind of plan for a few. You want to dilate them a couple times relatively quickly, but we don't know. But one of the things that came up in that discussion is, how do you do it? Do you go in and you dilate it one time and keep your fingers crossed, or what? And there's no data for this, but I know it's safe.
You were showing an 18-millimeter balloon.
I know, well, yes, and the study showed that a 15 was just as good as an 18, so no reason to go big. But I personally, we can ask everybody what you guys like to do. I like to dilate it 3 times at once. I go down, if I'm gonna be there, I go down, I try and actuate the beads 3 times, and then I'm done. I don't just do it once, but what do you do, John?
Even the smallest links device we have opens to a minimum or a maximum diameter of about 21, 22 millimeters. So dilating 18 isn't going to do anything to damage the links itself per se. What we're trying to do is just break up the scar that you saw on her video around that. So I'm like Chrissy, I go down there and I usually will blow up the balloon 3 times or whatever, or move the balloon back and forth to get it to really break it up.
But it's one session.
Yeah, one session.
That only counts as one.
That's one session.
It only counts as one.
Why do you use a balloon as opposed to a bougie? Savory?
It's just easier, quicker. If they're not responding after the second session of dilating, then sometimes we'll go to a savory or whatever.
But also, I like to think of it as, I don't know how many people have experience with like the burn unit. You know, the burn unit, when they have really bad contractures on their hand, they give them those compression garments and they massage their hand all the time. It's the same thing. If we could massage it and soften up that scar, it'd be great. We can't. The way we do it is with a balloon. Do it a few times.
Never thought about having
It
my
is-
esophagus
I mean-
massaged, but
I mean,
now I'm all excited.
It's from the wound literature, the wound care literature people. And
Hey,
so
John.
we're massaging the esophagus. That's the way I look at it.
Reg.
I'd just like to mention that if a barium tablet holds up on a lynx, that's not necessarily abnormal.
Right.
Peristaltic amplitude varies depending upon the size of the bolus. A barium tablet is 1 cc. And you need about 30 millimeters of mercury pressure to pop open the lynx. So if you just see a patient with some mild dysphagia, barium tablet hangs up, do a time barium swallow or some other study to demonstrate that if you think that that's really an issue. So anyway, just mention that.
Yeah, that's a great point, Reg. I agree. We frequently see that tablet hang up there at the GE junction after links for a while. Most of the time it means nothing. Robbie, you have something? Oh, sorry.
Yeah, I would have to say I strongly disagree with the idea of dilating with a bougie because there's clearly shear force involved in a bougie that is not there with a balloon. The only dilation-related explantation I've had to do from an erosion was within a month or so after a bougie dilation was done on the GI service. So I shared the dilation protocol with them because they were really unaware of what we had in terms of a balloon protocol. So
Can you share your balloon protocol?
Say again?
Share your protocol if you would.
Right, it's the published one. It's the one you sent me.
Right. No, I thought it was going to be different.
But,
it wasn't.
And the recommendation not to go beyond 15 millimeters is ridiculous because that gets you nothing. I look at the chart of what I can expect with tissue and dilation, and typically we'll go to a minimum of 18 and sometimes go to 20. But you look through that balloon and sometimes you can see the gray of the beads through the mucosa. So that just tells me that if I were doing that with a bougie, it doesn't take much shear force before you just unroof a little bit or cause enough ecchymosis that you're looking for an erosion soon.
Yeah, I agree. I rarely use the savory, but Robbie.
Yeah, so post-fundoplication dysphagia, I have done not many, but several pneumatic dilations. The savories, go up to 20 millimeters, usually don't work, at least in my experience with post-fundoplication dysphagia. And I'm not talking about immediate ones, the long-term ones. They're still having symptoms after a few years or whatever. So I didn't hear any comment about pneumatic dilations for post-fundoplication dysphagia. That was one. And does anybody has any experience with the links doing pneumatic dilations? Does it cause any problem?
The answer is yes. Oh, there he is, and he's right here. Woody has got the world's most experience with pneumatic dilatation after links.
So over 700 implants, about 130 pneumatic dilations. 90% of our patients, one dilation, one session, they're resolved. No erosions, no esophageal injuries. We don't just go like we use a 30 millimeter balloon, but the protocol isn't to inflate to 3 atmospheres. We inflate under fluoro until all beads are equally separated, and then hold that for 1 minute and then drop the balloon. Had great success with it. Not published data, however, so it's just my anecdotal.
0 explants, right?
That's correct.
So that's unheard of. 0 explants, links, and dysphagia issues. Most of us, our center, we hover between 3 and 5% explants for dysphagia. So to have 0 pneumatic might be the answer.
And what about post-fundoplication dysphagia?
Well, there was a recent randomized controlled trial that came out within the last 5 years that said that didn't work, I thought.
Well, yeah, that's fine to say it doesn't work, but the stuff you guys are doing is not controlled. So, I mean, let's be fair. Just because you're not better than a placebo doesn't mean that it's not a treatment that you might offer the patient.
I didn't say that.
I understand. But
I don't know where you're putting words in my mouth.
You just comment on Robbie. So the bottom line, Robbie, is we do it. or I do it, if a traditional simple dilatation does not help and the patient doesn't want to have an operation, surgeon's not ready to reoperate. I find it incredibly safe. I can't prove to you that I've done hundreds, but I've done more than enough to know that I'm comfortable. And with fluoro and a good backup with an interventional endoscopist, I think it should be no problem at all. And I would probably use EsoFlip.
I agree with EsoFlip on that
I want
one.
to add to that, though. I think if you are, I have no problem trying that. Like, go ahead. But if you are moving to the decision, like if you've tried some simple dilations and now you're moving to Rigiflex and all that stuff, I just ask that you should probably get your surgeon involved at that point, because we're all trying to figure out risks, benefits, right? And if it's going to be what we would consider maybe an easy redo versus a difficult redo, that might impact how aggressive we want you to be endoscopically. You know, but I hate it when I have a patient who's been in somewhere with GI getting all these dilations for months and months and months and months, and it's like they just needed a stitch removed, you know? So I just ask that we collaborate at that point.
You know, one thing about this post-fundoplication pneumatic dilations, every time I do it, I cringe, but I've never had any problems or perforation. So I think it's safe for the post-fundoplication dysphagia pneumatic dilations.
I agree it's definitely safe, and I agree you should, and I've tried it also. Dan?
As far as using bougie with links, I would voice a concern. Doing it blindly, you do risk putting the bougie out the side of the esophagus. So if you're going to use a diagram,
Nobody uses that type of bougie anymore. It would be over a guide wire.
Yeah, guide wire.
All right, anything else before we move on to Ellen? Stu's got something burning.
Yeah, well, not burning, but thank you. No, I just want to, first of all, I really enjoyed the session, but from what you're telling me, that at least with these post-length dysphasias, that we really don't want to gradually dilate that. We want to rip that thing apart.
Yeah.
Right? So the idea of gradual dilation, we shouldn't be doing that.
The video was very compelling, that you're breaking scar.
Mm-hmm.
Yeah, so you got to break that up. So we shouldn't gradually dilate as if it's a peptic
The
strip.
term we use is go big or go home.
Yeah, go big or go home 3 times.
Nick, one last question.
Just one question for everybody here, because amongst the 4 options, there wasn't remove the links and do nothing more. So I just wonder, if the dilatations failed in this patient, what would people do next?
That's a great question. So I'm going to go first real quick, and then I'll open it to the panel. What we would do if they fail 3 dilatations, again, definition of insanity, we're going to remove that device. If they don't have recurrent reflux, English was a major, then we're just going to take the device out and do nothing else. We published on that a couple of years ago. It's about 75% of them don't get any recurrent reflux, but their dysphagia is resolved. But I'm curious to see what everybody else would do, starting with Stephanie.
Yeah, so I've read your publication, but that's exactly what I would do too. Because often they have that scar there from where that links was, and so adding like a toupee or something, I don't think it really is necessary. So just leave it out.
Brent? Christy?
I think it depends. It depends on the patient. It depends on whether or not medications were an option for them originally, and what they want to do about it and how severe their reflux was. I think it.
So in this case, there was the story of the lady who didn't want to take a PPI because.
No. Well, I mean, but it just depends. It really does depend. Some people, they have very severe. They had a real serious reason. It wasn't like that. I think it's amazing though how so many of them are okay with that scar tissue.
Yeah. Now I will make one last plug for Dusty. And if Reg is still here in the audience, maybe he can speak up to this. But both him and I have had a couple of experiences where we've gone in to remove the links, opened up the anterior capsule, took the links out. Patient still had dysphagia. We then did EndoFlip on them, and the DI was less than 2, whatever. We go back in there, and what was kind of preventing things from opening up and why they still had persistent dysphagia was the interior portion of that capsule, that scar. Reg, comment?
really goes to the point. So this patient that I operated on had already been re-operated on by another surgeon who took out the links.
Was it Tripp?
And continued. No, it was you.
Okay.
And then Tripp. But have been re-operated on by the initial surgeon, the links taken out, dilated 2 or 3 times, still no response. Came to see me, and we went in, and again, didn't see anything really abnormal, except it just looked like I didn't see longitudinal muscle fibers. So we put the endoflip in, and the DI was like 1. And so we spent an hour just gently stripping off some of that scar tissue off the esophagus, right where the links had been. And the DI went up to normal range 3 or something. So yes, be cautious about that and thoughtful, because if you're having to remove a links for dysphagia, think about what resources do you have.
Yeah, so the moral of the story is think about using EndoFlip when you're removing it, you know, because maybe it's actually the hiatal closure that's causing the dysphagia and not that links, or maybe it's that inside band. But anyway, I think we've overstayed our welcome, and now
Case
it's
3.
time for the Ellen Show.
So for the third case, Ellen Stein is going to present this from Rutgers.
All right. Am I on? All right, I'm on. All right. So it didn't work. Those were the patient's exact words, and he'll be thrilled that he's going to be presented here today. So I'm going to take all of your advice back to him. This one? Okay. So when to promise surgical solutions? So he's a 51-year-old guy, and he had regurgitation, trouble swallowing, and chest discomfort, but that didn't really bother him. It was this fullness sensation in his throat, cough, and just this belching, and he said he only had mild anxiety at baseline. His esophagram showed just a slight delay exiting the esophagus, and despite max dose PPI and H2 blocker confirmed the appropriate timing, he had lost 30 pounds with a keto diet to try to get in shape and get rid of his reflux, but he still had bothersome daily symptoms. But mostly he wanted me to fix his throat and his globus. So at the first visit, we talked about diaphragmatic breathing. We had elevated the head of his bed. I talked about hydrating more, getting rid of the mucus that was in the back of his throat. And then after several months, that wasn't working, so we referred to surgery. Now, before we did that, we did a manometry, which had a nice, beautiful peristaltic pattern, a small hernia, but nothing spectacular. Now, he had an endoscopy, and off therapy, he had LA grade B esophagitis, but on therapy, he was grade A, so he had good reflux control on his current therapy. The lower third of the esophagus looked well healed, so it just didn't all add up. He had a Hill grade kind of 2 when you sat there for a while, AFS grade 2, and we looked carefully. And on his testing, his Bravo showed that the Demeester was positive and the acid exposure was positive off therapy. So he really had GERD, but he wanted me to fix what I wasn't sure was GERD. So he had the surgical operation, and about 2 weeks later, he says, "I am dying." And there was a 7-page MyChart message of how, in the many ways that he was dying. He had already gone to the ER twice. He said he can't live like this. He can't do all of this anymore. It didn't work. And I looked, and I am very privileged. I actually work with Dr. Hoppo, who's one of the foregut surgeons from this conference. You'll see him speaking later in the talk. So it was a good surgery. And I knew it was a good surgeon who really thought carefully about his surgery. And he did a robot-assisted lap hiatal hernia repair. He did a classic Nissen. Everything went smoothly. The operation was great. The post-operative course was totally normal. So I rushed him into clinic, and I evaluated him. And again, the fullness sensation in the throat, a little bit of chest discomfort in the globus were what was driving him absolutely nuts. And he also had new gas and distension, some increase in bowel movements, but all of his classic heartburn symptoms were gone and resolved. So we talked about that, why that was a good thing. But one thing you would want to ask is, why would this happen in somebody who you thought had more of an LPR scenario? So I think there's a question and a poll, but I don't know how to
Hoover.
Hoove it up.
one person answering.
I know. 7 people so far. Is it up there? I think he's going to reload it.
We've only got 7 responses recorded here.
I think all 7
Can we
people got
refresh?
it. There we go.
That's better.
All right, so I think everybody kind of agrees that LPR laryngoscopy is not a diagnostic modality that we all rely on, that LA esophagitis doesn't always conclude that there's GERD, especially when done off therapy, and that your classic symptoms of postprandial epigastric discomfort and heartburn are kind of more classic. So those are all the reasons. Did we go to the...
There you go.
There you go. Okay, so what did I do? First thing I told him he wasn't dying, and I reassured him of that, which took about a half hour to convince him that he wasn't actually going to die while he was in the office. And knowing that he had anxiety, we talked about how operation recoveries take more time than 2 weeks. We talked about getting back on PPI therapy for a little bit, and I think all of the people on the stage said it's not a failure to go back on PPI therapy for a little while. And we talked about, maybe the LPR wasn't reflux to begin with, and what else could we do? And we talked about gas bloat and how you can get more gas after surgery. I think in his mind, with his anxiety, every one of those was a new problem that had come up post-operatively that had to be evaluated, and it was a sign of something awful going on. And I think you have to be ready to tell your patients what to do. And I will say that this is one of those patients who had an anxiety level that was palpable from the door, and who 5 other surgeons had said, a surgery is not right for you. So it took a lot of work with this fellow to get him to a place where surgery might be an option. And so you don't just necessarily throw away the patient after they have a complication. You have to be ready to work with them. So I find LPR hard to manage because people have vague symptoms, voice change, throat clearing, burning mouth, ear fullness, full sensation in the throat, and if they had a symptom index of 50%, what are you going to do? Or where do you go with that? It's kind of how much you trust in the patient, and where you feel like you can promise things. So I promise what I can deliver, and I deliver what I can promise. So your classic symptoms, as we know, were likely to improve. Your heartburn, your regurgitation, your chest pain, belching, and acid rash. And if somebody's dying of another symptom, I can't promise that it'll get better, but it's likely to get better. And so what you promise those with LPR is that the ENTs have a lot to say about what they're seeing, and I have a lot to say about what my testing shows. And I can make promises based on the testing that I get done. I promise acid relief based on the Lyon criteria, and then I say, look, I'll be there with you after surgery, and we can work to find solutions. And that generally works. And in this gentleman, we were able to give him some TCA, and he felt better.
All right, well, we have finally made it to my patients. These are the patients that are a bit squirrely, a bit crazy. I'm from Los Angeles, so this is my wheelhouse. So I'll present one of my own patients. Looks like we skipped a slide, Peter.
I didn't do it.
Oh, there. I didn't touch the clicker. 38-year-old female. That had nothing to do with what I had said previously. Heartburn, acid taste all the time, otherwise healthy, normal BMI, no other medical problems, no surgeries. Placed on a PPI, but I think their primary care, zero relief whatsoever, which should be a red flag for you right there. Was referred over to the gastroenterologist for GERD therapy, for workup. Got over there and went through kind of the normal routine, did an endoscopy, no esophagitis, no hiatal hernia, AFS grade 2. underwent pH testing, Bravo pH testing, I believe. Completely normal acid exposure time, no symptom correlation. This is my patient. And so what did I do? I took him to the operating room. I took him to the operating room and I did a Nissen fundoplication is what I did. What would you do? As Peter would say, it's Hoover time. Would you change to the new PCAB inhibitor? Would you put him on some other sort of mood-altering medication? Refer back to me for a redo surgery? I'm beyond help. All right, bring up the poll. Oh, interesting breakdown. All right, well, to learn a little bit more about this, we're going to bring up John Pandolfino, who also needs no introduction.
So remember this output here.
Yeah.
And we'll see how you feel about it after you listen to John.
Well, I was really upset when I got this topic. This is not my favorite thing to speak about, but it's obviously something that is pretty important. I consider myself a plumber at heart, and many years ago I realized I could fix the plumbing and people wouldn't get better. And with that, I introduced myself to our psychologists, who are now called gastropsychologists, who really changed the way I thought about all of these particular problems and usually work hand in hand with them. So when you think about these patients, it's important to start thinking about all of these patients, not just the ones who have normal physiology and normal function testing, but all of the patients that you see actually have a disorder of gut-brain interaction. If there wasn't a gut-brain interaction, they wouldn't have symptoms. So they all have some degree of symptoms. And this is the classic definition, that these patients have to have absence of structural abnormality, motility abnormalities, or any evidence of reflux. Oh, are they not going up? Now they're up, okay. Okay, well, you guys missed the definition of functional esophageal disorders. You probably all know it. So anyway, going through this process, one of the things that I think has been really important is that we know that there is this relationship between physiology and how you perceive symptoms. And there are some people, and this is a beautiful study by Satish Rao, who actually perceive things at a lower threshold, right? They're hypersensitive. They have visceral hypersensitivity. And when you actually assess these particular patients, many of these patients can have symptoms that are typical of our reflux construct. But really, when you start to think about these patients, you really have to start to conceptualize all of these patients in context of their abnormal reflux burden and then their level of perception. And that level of perception is actually based on their underlying visceral hypersensitivity and hypersensitivity to the vigilance. How vigilant are they of these symptoms? Do they feel everything? And if you only count on one of those, if you only fix the abnormal burden and you leave the other, that patient's going to be unhappy, regardless of what you do. You could do the best surgery, the best endoscopic procedure, and these patients are going to be unhappy. Now, this was the old paradigm. This was dogma. It used to be this thought that the only patients who had visceral hypersensitivity, hypervigilance, anxiety, were patients who had normal anatomy and normal physiology and no acid exposure. But what we later found was that all of these patients have some degree of visceral hypersensitivity, hypervigilance, and you need to consider that in all of the patients who present with reflux, not just organic disease versus functional, all of them. And if you discount that, you will leave many patients behind, or you'll leave patients, as we saw with Ellen's patient, sitting there worried afterwards if you don't preemptively kind of address that. And really now we have a new construct where we have this psychophysiologic model of GERD. I preferred the psychopathologic model of GERD, but my psychologists thought it would be bad to call it psychopath. They only call me psychopath. So now, when you go back to how we manage reflux, when we use these empiric trials, the one thing I will caution people about, empiric trials are not very reassuring for patients. Because in essence, you're guessing, right? You're guessing that this may make patients better. And then, there is this huge placebo response. So I do believe that this empiric protocol that we use many times actually feeds into a lot of these issues. So that's why we really advocate for upfront physiologic testing. So we actually know what the answer is, and we can actually tailor the treatment for the patient. And that really is personalized medicine. That's Hippocrates, who was actually the first person to talk about personalized medicine. And this particular case, he really focused on, obviously abnormal symptoms. He didn't have reflux testing or anything like that. But now we can actually phenotype patients quite well. And really what we need to be doing with these patients is we need to actually parameterize their underlying psychosocial stressors, hypervigilance and hypersensitivity, up front, so that we can address those up front before they maybe get surgery or go on to something else, because then they'll actually have expectations that are in line with what to expect. Now, for Globus, I would have probably sent this patient for gut-directed hypnotherapy, probably the best therapy for this that has been published. Very effective treatment for Globus, and certainly much better than surgery. And then, of course, if they don't respond to these behavioral therapies, you can go ahead and try some antidepressants or low-dose neuromodulators, which are also very effective. But the bottom line is we have to start conceptualizing this disease as not just an anatomical issue, not just a physiologic issue, but also a psychological issue. And if we don't address that, we're only going to be treating half of the patient. And I think there are many times where you see people like John's patient where I wouldn't have touched that person with a 10-foot pole. That is a person that if you would have gotten an EHAS score, the EHAS score would have been 45, and I would have said, see my psychologist first, and then after they get you fixed, then we'll come back and readdress and then determine whether or not you get surgery. But it'll also make them feel a little bit more comfortable after surgery, and I think that's the most important thing. So if you don't have access to a gastropsychologist, you can find them on the Rome Foundation GastroPsych page, and there's a very nice handbook that has been developed by Lori Kiefer and the crew at the Rome Foundation that can help you with this. So treat the whole patient, not just half the patient. Thank you very much.
All right. You get another chance. This is the same question. What would you do?
Well, I think reading between the lines, John said to operate on them and then put them on medication, right? Isn't that what I heard? Yeah, surgery.
You want to refresh that? We've got only 11 responses here. Oh, no.
What happened to the poll?
You had an impact, John.
There's 7 that are in my camp. Yeah. Look right there.
Oh, it just went down. No.
I think me and those 7 people need cognitive behavioral therapy.
You convinced 72.
What do you think, Ellen?
I think it's easier said than done to get people to agree to cognitive behavioral therapy. And this guy, he's like, why do I need another therapist? And it's so, there are patients with mental health disorders who already have a therapist, who you talk to the regular type of therapist and they're not going to be able to do the same thing. You can guide them, you can hope that they're willing to work on it. But for this guy, his problem had always been he had real reflux. You can't walk your way, talk your way out of real reflux. So I told him I was going to take away the reflux and then we'd work on the globus. And that ended up working.
You know, I think that's one of the obstacles, the way you phrase that, as a mental health disorder. And that's why I think a lot of people are resistant to the concept of cognitive behavioral therapy, because they're telling me I'm nuts. And it isn't really what you're telling them.
That's what I can tell. We're ahead of schedule, right?
Yeah, we're good. We're good. We go to at latest 3, right?
Questions? Anybody?
So I was just going to say that one of the things, I think the interaction with the patient is very important. So a couple things that you should be doing is coming up with a script that so for me, I'll ask them, if they're wearing glasses or a wristwatch, can you feel that? And they always look at me like I'm an idiot, and they say, yes, I can feel that. I'm like, well, you didn't feel it a few minutes ago, and you won't feel it 5 minutes from now, and that's because your brain filters that. And right now what's happening is you're keyed in on your esophagus. You're going to feel things that you shouldn't feel because you shouldn't feel your esophagus. And what we're going to try to do is we're going to try to use behavioral therapies to divert your attention away, whether it's hypnosis, cognitive behavioral therapy, acceptance commitment therapy, just so that you can live with this and it doesn't bother you anymore. And when you start to explain it that way, and you explain that there are psychologists that have a special expertise focused on this particular component, then I think they're much more apt to do that. I will tell you, if you ask patients, 2 to 1, they're much more in favor of a behavioral approach than they are a low-dose antidepressant, because the low-dose antidepressant has a stigma, and it also has side effects that patients don't want. They already don't want to take a PPI, and then you start telling them they need to take a TCA, that's even worse.
Ladies first, Felice.
Thank you. So my question has a little bit to do with psychology as well. I often find if you're sending someone who has bona fide reflux for anti-reflux surgery, that they actually don't have any sense of what a tight sphincter would feel like. And so they undergo surgery, and now they think something is wrong. And they no longer have heartburn, but they're feeling things. And they're feeling things because for many decades, they had a very wide open valve. And they were used to the way that that valve felt when they ate and everything else. And so it's not really sometimes this psycho issue for them. It's actually retraining them on what a tight valve now will feel, because it's a new phenomenon for them. And that is what I find sometimes takes time, but we don't really often have the words for that for them, meaning this is now your new normal, but it's a good new normal, and your brain has to start to realize that this is what we were trying to achieve. So my question to you is, do you have ways for us to do that? Because I do think that this is another piece to this that's different than leftover symptoms.
Question at the mic.
Dan, you want to go over?
I'll let Casey. I always like to hear what Casey says.
Okay.
And I think alike, so he may obviate my question.
I admire the work that you're doing because I think it's an underappreciated field, but the reality of it is most of us don't have access to anyone that has any idea of what gastric psychiatry looks like. So in reality, in my practice, what I probably would have done with this patient is repeat the pH study, because they're going to be in disbelief that they have reflux. There is roughly a false negative of 10%, so I do have to come back to the patient and say, really, you don't have reflux. Because the practical side of this is I'm just going to have to simply refuse to operate on them, and I'll try antidepressants and other things in my practice, but the reality of it is at some point we come down to refusing to give them the treatment that they've been told they need.
So that's a great observation, and I will say that right now that problem is definitely being addressed. There are third-party groups and companies and products out there that are digital-based or virtual psychologists. So you're going to see this onslaught of programs from Able Health, Vivante Health, that are going to be able to essentially do this over the internet or even over an app. So I think this is going to be much more widely available, and I think that would be beneficial. I do see a lot of people who were exactly in that spot that you were in, and then they wind up seeing another surgeon, and then they say no, and then another surgeon. And we just kind of break that cycle. And I think the acceptance commitment therapy is also a good thing, because at some point these people just have to learn to live with it. You know, because if the surgeons are not going to operate, they have to accept this is what my life is like, and I just have to make the best of it. And that does require someone with expertise in that particular therapy.
It's an area that really lends itself to remote medicine. So you don't have to have in-person contact. And I think they're the one group that actually benefited from COVID, because they developed this into a telemedicine or Zoom.
I'd love to know what those resources are.
There are a whole bunch of online apps that are available some are FDA approved digital therapeutics. I think Dusty gave the talk on it last year. And so I think some of the vendors may be here as well. But there's Nerva, there's one from the Veterans Department, there's some available from the UK. They're free, they're widely available, some you pay for, like therapy. What I would say is the basic tests, so if they're not gonna go see a doctor and they're not gonna go see a therapist, they're totally anti any kind of antidepressant, the thing I ask everybody is, what do you love to do? And most often for women, it's I love my garden. For guys, it's when I'm in my tool shop and I say, okay, great. How do you feel when you're there? And 95% of the time when they're engrossed in an activity that they absolutely love to do, the symptom gets better, whatever it is, because they're totally focused on something else. You can't have the focus all be on something. So I told one lady, yeah, just go in your garden for like 10 hours a day. And she laughed at me. But she did it. She went out in the garden every afternoon whenever her symptoms were really terrible, and she loved it because it worked. So it's a simple thing that they can practice without going to therapy, and once they start to see the benefit, then they come back and they want to be referred somewhere. There's a lot of online availability. You just have to explain what the disorder is. And so I think what you were really good at pointing out was hypervigilance. Hypervigilance means you're totally way too aware of a symptom. It's there, it's happening, but you're not dying. So you as a physician have to state that out loud in the office. You are not dying. And I find that gently diffuses the tension. And then nothing bad's gonna happen, because if you ask, I had somebody with esophageal cancer in my family, I had somebody who died of a hernia that migrated. There's always something they're terrified of. And if you can diffuse that and then get them to find a path to the right therapy, you'll go a long way.
I think what I heard is Ellen says I just need to drink more.
Yeah,
this is what I like to do. Dan,
that's what you like,
been
John.
waiting.
Glad you got to me, because as I'm standing here, I wanted to run away from this mic and talk to my therapist. Wondering why, as someone who does almost exclusively revisional surgery, why the one time I choose to stand up and speak is on gastropsychology. But that said, John, I do have a question. I think what I heard you say is that it's important to address the potential that they do actually have reflux before you start navigating them into this cognitive behavioral therapy. Did I get that right?
Yeah, I mean,
early on, objectively assess their symptoms before you empirically try to treat them. Talk them out of their symptoms by saying, well, gosh, you're on double dose PPI. It's not reflux. It must be in your head. Go see a cognitive behavioral therapist. Did I hear that right?
Exactly. I think you have to phenotype these patients appropriately up front, because if someone has normal function and you try to make it more normal, you're just going to make them abnormal, right? So I think in the grand scheme of things, you have to think of it not just as a dichotomous line in the sand. You either have reflux and you don't have reflux, and the people who don't have reflux therefore are the only ones with psychological distress. That's when you get into trouble. They all have some level of psychological distress. They're ill. They're chronically ill.
Well, and to jump in my practice, I validate the reality of their symptoms early. They trust me. And then when I give them objective data, they're more willing to accept my influence.
Yes.
Especially if it says, I can't help you. Your medicines haven't helped you. I think this is a viable path. But if I drop them into that, this is all in your head, and I haven't investigated it objectively whether they have those symptoms, I get nowhere with that patient.
Well, that's the flaw of empiric trials. I mean, I think what they do is they don't reassure people because you're not reassuring because you're guessing. And that doesn't make people feel comfortable. So you go through that process and you don't really have legs to stand on when you say you don't have reflux because you don't know that they don't.
You haven't assessed it, and it's a big deal, and I'm only belaboring this because that's a great message for gastroenterologists to hear. Because the typical path I see is empiric therapy, failure, and then either neuromodulators, hypersensitivity diagnosis, or referral to a surgeon. And these patients are still feeling largely abandoned, and then nobody's listening to what they're experiencing and actually objectively assessed it. And to Casey's comment, you're spot on, Casey. I mean, the best thing you can do for, I think, all surgeons, and me too, is give us those tools up front. I think every patient, before they have an anti-reflux surgery, should have some sort of a, you know, we do GERD RQLs and everything else. We need an anxiety rheostat. Where does anxiety fit into your symptom complex? Because we can fix reflux, but we cannot fix anxiety. And I've a substantial number of these patients who have surgery after surgery after surgery. I've had their anxiety under addressed, and they're trying to fix their anxiety with surgery. And surgeons are trying to fix it with surgery.
So the EHAS score.
Those are the patients, frankly, that finally realize that a plane ticket from LA to Atlanta isn't that expensive.
I send them all.
Until I can get them to go back to you, and you know exactly what I'm talking about.
I do.
So the EHAS score is readily available. It's been published. It's kind of exactly what you said. When you walk in the room.
I'm sorry to interrupt. How many surgeons know about it?
Yeah.
How many know about the EHAS score? How many don't? Yeah, so.
Well, now everybody does.
There's an opportunity there to
Yeah.
do that. Sorry. No, thanks, Dan. No, you didn't.
It's esophageal hypervigilance and anxiety scale, EHAS.
Yeah, and so we should. Hang on. And I'm jumping in front of Dr. Bashashati, who's my GI neurogastromotility expert and colleague from UT. So that's the reason why I'm jumping up here. So it was at the very first AFS meeting, and their paper, their EHAS paper came out, and I went up to John and Peter and I'm like, hey, can I borrow this? And we studied it so you can PubMed it. And we looked at surgical patients because I think part of us as surgeons think, are these patients crazy? Are they baseline hypervigilant? Are they baseline anxious? Or because they do feel somewhat abandoned, probably not by this crowd, by community GI at large, are we making them crazy? The other thing was, I never liked the too crazy for links idea. And so we looked at it, links, toupees, Nissens, and we found that EHAS scale in general came down by half. Now there's for sure a cohort of patients that we cannot help with surgery. And what we have not done yet is tease that group out. But I think, we talked with John, with Peter, and I think it's really exciting. And so, yeah, just PubMed it and start looking at your patients and see where they are, because sometimes patients are off the charts and you can really help them. But you have to be super specific when you look at it. You've got to do all the objective testing. You've got to really lay out the expectations for those patients. Thank you.
Hi, my question is to Dr. Pandolfino. Based on your experience, how much is the success rate with cognitive behavioral therapy? It usually fails, because when you offer to the patients to go and talk to a psychologist, they will come back to you and tell you, am I crazy? This is what I hear. So you usually need to combine that with neuromodulators. And in my practice, I realized that means involving a psychiatrist is much more helpful than sending to cognitive behavioral therapists, because they can go beyond PCAs. So just wanted to.
Yeah, so, I mean, obviously, neuromodulation does have a place, and I think, at least for us, many of the patients don't want the stigma of an antidepressant, and they don't want the side effects, right? The gabapentins and Lyrica, and, those have significant side effects, and obviously the antidepressants have a stigma and side effects. In terms of success rates, if you send them for cognitive behavioral therapy to a person who doesn't do gastropsychology, they're not going to get better, because that person's going to talk to them about things like their parents, which really doesn't affect that much, right? You really have to focus in on the symptoms. So if you look at hypnotherapy, a lot of great data in chest pain, very effective. Small series in Globus, very effective. We are now doing a randomized controlled sham trial on acceptance commitment therapy versus standard of care lifestyle management in patients with functional heartburn and also patients with GERD documented on pH testing. We have a paper that is being reviewed currently in patients with dysphagia who have undergone acceptance commitment therapy with pretty significant improvements in their overall symptoms. So you have to get the right expertise, and I think that as these digital platforms and these virtual platforms are going to become available, this is very easy. It's literally 5 weeks, 1 hour a week, and they can do it in their pajamas. I can't hear him.
We can't hear you in the back.
The issue is that patients don't want to go, is what he's saying.
Actually, the patient acceptance for cognitive behavioral therapy is way higher than taking a neuromodulator.
So this brain gut disorder, I have a problem with. We're calling people functional, we're calling hypersensitive esophagus. We do manometry and pH monitoring, and if that's normal, we say this is hypersensitive esophagus. So assumption there is that we are able to measure all physiological parameters of the esophagus, which is not true. Half of the muscle mass in the esophagus is longitudinal muscle.
Oh, shit.
And we are not monitoring that. Our data shows that a lot of these symptoms, the genesis is in the longitudinal muscle. When the longitudinal muscles contract, the blood flow to the esophageal wall stops. They have ischemia of the esophageal wall. And a lot of chest pains, we can correlate that with that. So the problem, we can call until we have good solutions, we can call them functional. But I think there are huge implications for calling somebody functional. And I would be very careful. If we continue this path, I don't know how much progress are we going to make in this field.
So I think there certainly are disorders that have not been defined by our current modalities in terms of esophageal function testing. So the diagnosis of functional heartburn or reflux hypersensitivity are not perfect, without a doubt. And I think functional heartburn in particular, we showed that even with FLIP. If you looked at the Rome diagnosis of functional heartburn, a good chunk of those patients actually have a very abnormal FLIP. So are they truly functional heartburn, meaning they have normal physiology, normal anatomy? No. So there are other modalities that could potentially help us uncover that. That being said, though, there are this group of patients who have seemingly normal function, no evidence of reflux, no symptom reflux correlation, who you put through hypnotherapy or cognitive behavioral therapy, and they do get better. So I think those are probably the patients who really have hypervigilance as their underlying driver of symptomatology.
Yeah, it's clearly a moving target. There's a set of disorders that we know and a set of disorders that have yet to be discovered, and then there are the ones that are attributable to hypervigilance or whatever.
I think if we keep assuming
a unique.
The last thing I want to say is based on Stu Speckler's study in the New England Journal on fundoplication versus, the other medical therapy. Clearly, a lot of those patients got better. 70% got better. So there is definitely something more than just meets the eye, and that we will only discover if we continue to look for things that we are not looking for. And if we continue to call this functional, I doubt we will make a lot of progress in this field.
Well, I think in Stu's paper, though, the people who had negative testing, you ruled out. The people who responded were people who actually had a symptom reflux correlation.
Yeah, no, that's exactly right.
Exactly.
But I do agree with I have a bit of a problem with calling reflux hypersensitivity a functional disorder, because those patients, maybe they're hypervigilant, that's I don't want to argue the point, but when you fix their reflux, they get better. Now, when we started that study, I didn't think that was going to be the case. I really didn't believe that. I thought these patients were just another functional group. But they did well. Now, the functional heartburn, I would not send to surgery for sure. But hypersensitivity, the reflux hypersensitivity, if you document it with the positive SAP, maybe SI, on the reflux testing, I think a lot of them will actually do better.
Yeah, I mean, the construct of hypersensitivity is that there has to be a stimuli. And if you remove the stimuli, they will get better. And I think that's what your study showed in those patients with weakly acidic reflux and the symptom reflux correlation.
Mike.
Guess I don't have to hand the mic off this time.
No,
so,
the mic to Mike.
From my own practice, I tell patients that there are two different ways of looking at medicine, right? You've got Occam's razor and you have Hickham's dictum. Right? Occam's razor, if you find one thing that explains everything, that's probably a problem. And Hickham's dictum is one of the senior GIs in New York who explained to me as a man can have as many diseases as he damn well pleases. But, I worry about patients, especially volume refluxers, who have both typical and atypical symptoms, or maybe just atypical symptoms because they're long-time refluxers and they've burned out that heartburn-type response. And that chronic cough or the throat clearing or the voice change or the globus are a sign that there's significant fluid getting up in there and they're aspirating or other complications that are brewing.
I think so.
And by blunting that with
we don't start the next session
neuromodulators, we are actually turning off a protective mechanism.
Should we start it a little
And so
early?
I guess I have a word of caution. I'm
give them
interested to
till
hear what
4.
the panel thinks about the idea of going at that neuromodulation first, because there may be some protection in keeping that around until the reflux is fixed and then treating that second, which has been my approach. And it sounds like, Ellen, that was sort of similar to how you approach it, but I'm interested to hear the panel goes at it, because it sounded like maybe there's some feeling that we could go to the neuromodulation side or the symptom side first with the CBT or other things. I'm worried about that in particular patients, but I'm interested to hear how you do it in your particular practices.
I mean, I think in terms of, when we use neuromodulators, part of what we're doing is also trying to tailor the side effects of those neuromodulators. So for instance, if someone has maybe a hypercontractile pattern on their esophagus and they're also having chest pain, a TCA with an anticholinergic property may be better. Whereas someone who has, IEM, you'd use SSRI because you're not having that anticholinergic, and that shouldn't affect peristalsis. There's really no data to support that. It's all anecdotal. It kind of makes sense, but does it really happen? I do think, once again, if you volume refluxers, that's real reflux. I mean, I don't really care. If I scope someone and I see gastric juice coming into their esophagus, I don't really need another test. Just like when I see an achalasia patient, if their esophagus filled with fluid and food and it's dilated, do I really need a manometry to tell me that's achalasia if I've ruled out pseudoachalasia? Probably not. I know that's blasphemy, but.
Any other comments from the panel before we shut it down?
And we're done early.
We are. We gave you back 7 minutes. So now we're going to break.
6.
6 minutes. We give you 6 minutes back, and if I keep talking, it'll be less.
Thanks, Dad.
We're going to break now until 4 o'clock for the Barrett session. So please go visit the sponsors, the booths. We'll see you back.